Right, we'll just wait a minute till the participants come in,
Sure.
and then we can kick it off at 8 o'clock sharp. Okay, well, good evening, everybody, and welcome to the SEATS School of Surgery webinars. And today's session is sponsored by Medtronic. I would like to invite, welcome everybody here today, and thank you for spending your time with us this evening with us. The first person I'd like to introduce is our first speaker, is Associate Professor Dr. Graeme Maclaren. Graeme is actually a good friend of mine and a colleague for many years right now. He's actually an adult and pediatric intensive care physician, and he's a director in the Cardiothoracic ICU in a National University Hospital here in Singapore. He also works as an intensivist in the pediatric ICU in the Royal Children's Hospital in Melbourne. Now, Dr. Graeme actually has published extensively on intensive care as well as ECMO. And to list all his achievements, you know, like I said, we'll take a webinar by itself. But I just wanted to bring forth that Dr. Graeme has recently published a lot of papers on COVID-19 and ECMO, and it's been published in the Lancet, the JAMA, and he is also one of the authors in the initial ELSO guidance document for COVID-19 patients in ECMO. So with that, Dr. Graeme, welcome to the SEATS webinar. And Dr. Graeme will be presenting today on ECMO for COVID-19 patients.
Thanks very much, Harish.
So we'll just get Dr. Graeme to share his screen. Okay, perfect. Thank you.
Is that up and running, Harish?
Yep, it's perfect. Thank you. We can start.
Great. Thank you. So thank you very much for the invitation to speak. This webinar is very, very timely for reasons that will become clear in a few slides from now. It's important to see how much we've learned over the last 8 months exactly about the role of ECMO for COVID. I have a couple of disclosures. One is that I'm a member of the executive committee of ELSO, but I don't receive any income from that. I have no ties to industry of any kind. I also need to acknowledge a friend and colleague from the University of Michigan, Brian Barbaro, some of whose slides I have borrowed in the middle of the presentation. So at the beginning of the COVID pandemic, as it emerged, as data emerged out of China, those of us who follow these things were very interested to know what the Chinese experience was with ECMO. Obviously, as a respiratory virus, we anticipated that a lot of patients might require mechanical ventilation, but if mechanical ventilation failed, then was there a role for ECMO? And in the beginning, it looked like there was not. This is a summary or slide, a pooled analysis of 4 papers with reasonably substantial numbers at the time of the Chinese experience with ECMO. If you just look at the column second on the right there, you can see that in these pooled analysis, there's 17 ECMO patients and only 1 survivor. So mortality is above 90%. So obviously this looks atrocious. The question was, is this something to do with the virus itself? Is it that if you have such a severe burden of disease, it doesn't matter what you do, the patient's going to die anyway? Or did this reflect perhaps inexperienced practitioners reaching for ECMO in desperation? Their healthcare systems were overwhelmed. Perhaps they didn't have much experience with ECMO and they were trying with it in desperation and failing. And that was not clear at the beginning. So we had speculation from a number of people. This was our speculation about exactly what ECMO can and can't do. In the beginning, of course, we didn't know enough about the virus, and in some respects we still don't. We didn't know how often it would affect other non-pulmonary organ systems. We didn't know how often circulatory problems would occur because of the virus, but it was clear from the beginning, from a report in the Lancet out of Wuhan, that circulatory problems were common, and that a number of patients had been admitted to ICU because of arrhythmias or shock. One message we were keen to get out in this publication early is that ECMO is a therapy for the select few. We can't use it in everybody. And of course, early COVID made itself very clear that it generally affected people who were elderly and vasculopaths. And taking very elderly patients with vascular disease and putting them on ECMO is generally not a good idea at the best of times anyway. So it wasn't clear whether ECMO was going to be much use. What we did want to get across, though, that this is not a therapy that should be pushed out. It's not a therapy that inexperienced centers or non-ECMO centers should be rushing to get up to speed with in order to deal with COVID. There was a number of other publications. This was one that we did trying to give advice to already established ECMO centers as to how to get up to speed, how to prepare for the incoming wave of COVID patients. We also had guidelines such as these from ELSO. You see the first author there, Dr. Bartlett, basically is the man who invented ECMO. So ELSO put out these guidelines really speculating as to what the role of ECMO might be, but this was all done in the absence of good data. It wasn't until mid-August of this year that we finally got some good data from experienced ECMO centers. And this publication came out of Paris. The Paris group were the ones who ran the EOLIA study, which is the largest randomized controlled trial of ECMO for adult respiratory failure. So this was a very important publication that a number of us were looking forward to seeing, because it was going to be very, very well-established ECMO centers dealing with COVID. And in fact, it's important to just flag at the beginning that these guys, they're real pros. This is the biggest ECMO center in the world. La Pitié-Salpêtrière Hospital does more than 400 ECMOs per year before the pandemic. They're very, very experienced. So what did it show? Well, at the time, they were looking at the period between kind of March and May, and there were 492 patients admitted to their centers in Paris, and 17% required ECMO for severe ARDS. There was a number of interesting features about this. Prone positioning has been shown in randomized controlled trials to reduce both mortality and the need for ECMO. Despite that, there are a number of recent studies showing that intensivists don't prone their patients enough for severe ARDS. In this study, however, there was fantastic proning. 94% of patients were proned before ECMO was even considered. That's spectacular, good pre-ECMO management strategies. The coagulopathy was a problem, as perhaps many of you would expect. Nearly half of them had a major bleeding episode, and extraordinarily, nearly a fifth of them had pulmonary emboli on ECMO. Comparing with the EOLIA study, for example, none of the patients in the EOLIA study had a pulmonary embolus on ECMO. And I'm not talking about trivial pulmonary emboli on VV ECMO, I'm talking about large pulmonary emboli, enough to potentially stop the pump, or to kill the patient, or to mandate switching over to veno-arterial ECMO. Almost all of the patients developed ventilator-associated pneumonia, and half of them became bacteremic. So again, this infectious morbidity is much, much higher than normal. Did this reflect something about COVID and what it does to the immune system? Or does this reflect the pre-ECMO immunomodulants the patients had, for example, steroids, or early as possible? But if you get it out too early, then you don't have all of your patients necessarily having met the primary endpoint, which means you have to do statistical modeling in order to estimate. So in this study, they knew the 60-day outcomes in almost all of the patients, but not quite all of them. So their estimated 60-day mortality was 31%, which is certainly better than over 90%. What other studies do we have? Well, just before we get there, just to recap the EOLIA study. So these are the same group that did the previous study. These are the inclusion criteria for the EOLIA study. So again, this is the best evidence we have of when to use VV ECMO for ARDS. It's randomized controlled trial data. And as you can see, it's pretty strict. Watching somebody with a PF ratio of less than 50 for 3 hours is very, very severe ARDS, despite recourse to a number of other maneuvers. This, of course, should only be done in an experienced ECMO center. If somebody was this sick and not in an ECMO center, then they would need to get to one ASAP, preferably on ECMO. You can't wait that long if they're not in an ECMO center. Just to remind everybody, this was the primary endpoint. Superficially, there was no statistically significant difference between the ECMO group and the control group. If you just look at the ECMO mortality, its 60-day mortality was 35%, so very similar to the 31% we saw in the previous study. The secondary endpoint, which is arguably more important in this study, so that was death or crossover to ECMO from the control group. There was a statistically significant difference. So in other words, there was a role for ECMO in severe ARDS. Even the New England Journal editorialists, who are not known to be partisan toward ECMO, acknowledged that this, whilst not a positive trial in the conventional sense, did show a signal towards benefit with ECMO. So the reason that this webinar is quite timely is because this study, which is the largest to date, only was published on Saturday morning, so only 3 days ago. Prior to that, it was under embargo. So when COVID came out of China, ELSO stepped in to change the way that the registry worked. So they created an addendum to capture data on COVID-19 patients in real time. Normally, the patients who are put into the ELSO registry, their data is only collected when they get discharged from hospital or they die. But ELSO recognized that there was a need to get data out there faster. So they created this addendum, and this was the first study which looks at this. So here we have data on 1,035 patients. They were censored on the 1st of May so that we could get 90-day outcomes for all patients. As of now, there's over 2,500 patients in the registry. But again, we don't know their outcomes quite yet. So this study was published in The Lancet 3 days ago, 1,035 patients. And it included all patients. They had to be PCR confirmed cases. They did not look at children, only late adolescents and adults, and those who were initiated on ECMO between mid-January and May. You can see that as a group, these patients were largely slightly obese, middle-aged males, so not dissimilar to your current speaker. Almost all of them were going on ECMO for ARDS. So 94% of them went on veno-venous ECMO, and 6% went on ECMO as mechanical circulatory support. This graph shows you, again, the difficulties of trying to rush data to publication so that clinicians can learn from them. So 6% of the patients we didn't have final disposition on. So did they die, did they survive, or it just was that the data managers hadn't had a chance to enter the data yet? We don't know, but only 6%, even if all of those 6% had died, it wouldn't make a huge difference to the results. So we're looking at less than 40% mortality in this large series, and that is independent of how you look at it. If you look at just those patients who either had died or got discharged, it was less than 40%. Or if you look at the primary endpoint of the study, which was the cumulative incidence of mortality at 90 days, it was also less than 40%. If we confined ourselves only to the patients who were labeled as ARDS, again, just under 40%. Of some note, about half of these patients had a tracheostomy on ECMO. And again, this shows the primary outcome of cumulative incidence of mortality at 90 days. So again, the majority of selected patients in this study survived. One question which has come up because of the coagulopathy that many COVID patients seem to develop was, well, is this coagulopathy interfering with the ECMO system? Is it going to increase the amount of mechanical failure, the need for circuit changes? And superficially, the answer is yes, it does seem to be associated with that. There were more circuit changes, etc., than when we compared them to non-COVID patients in the same centers in 2019. But once we normalized, in other words, once we looked at the incidence rather than the prevalence, so to speak, it was about the same. So the number of complications per 1,000 ECMO hours were comparable to non-COVID patients from 2019. Now, whether that was because people were adjusting their management strategies on ECMO to have different anticoagulation, again, that needs to be looked at in the future. Here we have some forest plots from the Cox analysis, just looking at basic risk factors for mortality. These are all independent risk factors. You can see that increasing age is an increased risk factor for mortality, particularly those patients over 70. The hazard ratio was above 3. There was no apparent difference we could detect with race or ethnicity. There was a number of conditions that you would expect to be associated with worse outcomes, such as chronic lung disease or a cardiac arrest prior to ECMO. And also circulatory support was associated with an increase in mortality. And again, that's something that wouldn't surprise anybody who does ECMO. Circulatory failure is associated with worse outcomes than respiratory failure for almost all conditions. So here's a summary slide. Again, thank you to Ryan for providing this. This is a visual abstract. So 36 countries, 213 hospitals, over 1,000 patients. And at 90 days after initiation of ECMO, less than 40% had died. So a lot of the strategies that have been looked at in previous studies of ECMO have looked at novel management strategies, but now because of COVID, people are looking at them more systematically. So this is one such example. This has appeared in JAMA Surgery. Again, it's not even in print yet, just like every other study that I've shown this evening. But what it did was looked at patients who were treated uniformly. There were 40 of them. They were treated in 2 centers in Chicago, and they were all treated the same way. They met the EOLIA criteria before ECMO. So I think it's hard to argue that none of these patients didn't need ECMO. 3/4 of them were proned prior to ECMO. And they used a relatively new single point double lumen catheter called the Protect Duo, which it sucks blood out of the right atrium, oxygenates it through a paracorporeal oxygenator, and then pumps it back into the main pulmonary artery. So it bypasses the right ventricle and thus acts really as a right ventricular assist device with an oxygenator in it. So these are newer devices. They're not available everywhere, but the outcomes in this study were very impressive. So at the time of publication, 5 of the 40 patients were still in hospital. 6 of them had died, so 15% mortality, and 3/4 of them had been discharged. Just to look at that data graphically, you can see that one of the aims of the study was to get patients extubated. So eventually all of them on ECMO were extubated, and therefore they were able to be managed with a single jugular catheter in. They could ambulate, they could talk, they could eat, etc. And you can see on the left the schematic of the Protect Duo going through the right internal jugular vein with the tip sitting just the bifurcation of the pulmonary arteries. So deoxygenated blood removed from the right atrium, pumped through this paracorporeal system, and then back in to the main PA, providing right ventricular support as well as ECMO. So despite this relatively positive signal, so in experienced centers, the majority of selected patients seem to survive with ECMO when they have COVID. There's a number of uncertainties. First of all, before ECMO, a lot of these studies were done before the publication of the recovery trial. So perhaps half, depending on the study you look at, maybe half of the patients were getting dexamethasone or hydrocortisone. I think nowadays all of them would be getting it. Remdesivir, again, we haven't seen any good RCTs looking at remdesivir in critically ill patients, although I know they're being done. So what we don't know is, well, is it possible that we could reduce the need for ECMO by using more corticosteroids than remdesivir, potentially in combination? Another question is, well, should we be using the EOLIA entry criteria? They may be apparently the best evidence-based guidelines for when to initiate ECMO, but is that relevant to COVID patients? Again, we don't know, and we probably wouldn't know unless we got a randomized control trial. That's probably not very realistic, but we'll see. Another question that's come up is, should we be doing extracorporeal cardiopulmonary resuscitation? If these patients have a cardiac arrest, should we all rush in and try and put them on ECMO emergently? And I think a lot of centers have shied away from that because of the risk to staff. Obviously, ECPR is quite often chaotic at the best of times. Doing it when the patient is infectious. People have to gown and glove and put on PPE. So there's lots of additional steps before they can do ECPR. So the outcomes are unlikely to be as good as they are in non-COVID circumstances. And some centers have just refused, because even if a couple of staff members get sick, that's automatically reduced your capacity to look after other patients. During ECMO, there are a number of uncertainties too. We know there is a signal that these patients do need ECMO for longer periods of time, and does that lead to more morbidity, such as the infectious morbidity we saw in that French study. We have some data from the study published in The Lancet, but it's hardly conclusive. Do we see more mechanical failure in the ECMO circuits because of the bleeding and thrombotic risk? Should we be screening for DVT and pulmonary embolus during ECMO? You'll recall the French study, 20% of them had large PEs. Perhaps we should be screening them more aggressively. And then there's a range of strategies on ECMO that are not currently accepted as a standard of care, but may lead to better outcomes. So one example, in the French study, 81% of those patients were proned, which during ECMO, which is, again, it's not standard practice. There are 2 studies now which seem to suggest that it may be associated with a decrease in mortality. So perhaps proning, not just pre-ECMO, but on ECMO, may be the way of the future. Some studies have looked at early tracheostomy or early extubation. Again, it's unknown whether that's associated with better outcomes. And then, of course, with the Protect Duo, do we see better outcomes if we are providing right ventricular support? After ECMO, the key question, of course, is what happens 1 year, 2 years down the track. We know 90-day outcomes, but what we don't really have are good measurements of morbidity. And I think it's very important when taking patients who are so critically ill that they need ECMO, we need to know at least 1 year outcomes. Did they survive, and what state are they in when they survive? We know that for non-ECMO patients and non-COVID patients, there is a substantial risk of long-standing debility, deterioration in psychological and physical health after being admitted to intensive care. And obviously being on ECMO, potentially for weeks, it's unlikely that these patients will be back to normal even 12 months later. So we need long-term data on these patients. We also need some evidence, should we be screening for thromboembolic disease routinely after ECMO? And lastly, how long can we do ECMO for and still have recovery? And is there a role for lung transplantation in those who get beyond that point? We don't know. So in conclusion, there does appear to be a role in experienced centers for ECMO in patients who have COVID ARDS. Other conditions such as multisystem inflammatory syndrome in children, or adults who need mechanical circulatory support for COVID-induced shock, we don't have so much data on that, but the early signs are encouraging that ECMO does have a role in those patients too. But we do need longer term data, and in particular, we need to focus on morbidity. Thank you.
Oh, amazing talk, Graeme. Thank you so much. That was very, very informative. We'll keep the questions to the end of the webinar today. Next speaker I'd like to present is Mr. Arthur Prevolos. Mr. Arthur is actually a senior perfusionist in Melbourne Austin Hospital, and he's also a medical specialist for Medtronic. Mr. Arthur actually worked as a perfusist in the Alfred Hospital for many years, from 1984 to 2012. He actually was the past president and the chairman of the ANZCP, and he's also been the chief examiner for the Australian Board of the Cardiovascular Perfusionists. So without much ado, welcome Mr. Arthur, and his topic today will be mini circuit for short VA ECMO assisted bypass.
Oh, thank you very much for that wonderful introduction, Harish. I appreciate it. And in fact, many years ago, I actually came to Singapore to run some exams when some of the perfusionists get certified.
Arthur, I just want to check. I don't know if it's my speaker, but I'm not hearing you very clearly.
Ah, okay.
Ah, that's better. Okay, that's better now. Yeah.
Good. All right. I just have to speak up. Speak up. Fine. Okay. So nice to see you. I think I'm sharing the wrong screen. Well, let me just see if I can fix that. Sorry. think I'd be able to work out the technical bits. Hang on, I'll move this. No, I've got, there you go. You can see my screen now? Good.
Not yet, actually. No, we can't see your screen yet.
Oh, sorry. Share screen. Sharing. Okay, I think that's it.
There we
Good.
go. Yep.
Excellent. Sorry
Okay,
about
great.
that.
Thank you.
It takes some time to get used to all this. I spent some time a few years ago in Singapore when we sat the first perfusion board exams there, so fun memories of it. And it's I'd like to thank the organising committee for allowing me to present tonight. It's greatly honoured to follow Graeme and Maclaren, who is now well recognised as a global authority on ECMO, and who I once had the pleasure of working with in Melbourne. And so I'll move on to tonight's presentation, which is about using extracorporeal support to support lung surgery. Here we go. So historically, the use of extracorporeal support for pulmonary resections was kind of limited to lung transplantation. And for patients undergoing lung surgery, airways management is always a problem with standard mechanical ventilation. And it can be challenging. And in some cases, it can be quite complicated by the patients having had either prior pneumonectomies or the presence of respiratory failure. So in complex cases which need tracheobronchial resections and reconstructions, we need to look at how else we can support these patients. These sort of images show you the kind of patients we can now present for surgery. And with a growing experience gained by surgeons during lung transplantation, more and more are now using extracorporeal support to achieve good oxygenation and hemodynamic support of these patients during challenging cases. If you like, it provides a surgeon with a margin of safety and a safety sort of net so they can carry out procedures. To that end, this is an algorithm by Roscoff. And they outline how they approach these particular surgeries. So if you've got a tracheobronchial or single lung surgery that needs to be done, the first question one you have to ask is, does it need hemodynamic support or is it an emergent situation? If the answer to either of these is yes, you follow the Venous-Arterial ECMO branch. If the answer to either of these is no, you go down the Venous ECMO support. The lower here shows the approaches that one can use for cannulation and entering the chest, either via stenotomy or thoracotomy. And it also leads to how one would approach the cannulation. But to the kind of support that we require, there are two basic supports. And Graeme outlined these kinds of support in his prior talk. It's either going to be veno-arterial or veno-venous support. And in terms of what the circuits look like, they're exactly the same. The difference is where we sort of access the blood, either out of the right atrium or the IVC, and where we return the blood. The veno-arterial support, it's using, for a second while I get my laser pointer up.
Arthur, sorry to stop you a little bit, Arthur, but you're getting very blurred. So if you could come a bit closer to your mic, we could hear you a bit better.
Is that better?
That's better. Yep, that's better. Yep.
So with veno-arterial support, we sort of pull out of the right atrium and return to the aorta. With veno-venous, we access the venous side and return to the right atrium. So let's look closely at the differences in the systems. With veno-venous, which is pulmonary support, our cannulation sites, we can have a single vessel, so we can have a jugular axis cannula, a dual lumen, where we sort of both drain blood from the patient and return using the same cannula and the same incision, which makes it terribly easy to deploy. Or we could use dual vessel cannulation, where we cannulate the femoral vein and return to the femoral vein. The difference being that we sort of separate the drainage and return to make sure we don't have recirculation. Further, if we need higher return, you can also cannulate the jugular vein up here to drain the blood. So you can have two venous drainage cannulas and one return. With veno-venous support, you get great patient oxygenation and it removes and CO2 extraction. Anticoagulation is always required for extracorporeal circuits, and this is monitored traditionally by the ACT. In determining how you anticoagulate your patients, most units have their own protocols for determining how much they need to anticoagulate for the procedures. For Venous Arterial, which provides cardiopulmonary support, or more complete support, the drainage and return sites are pretty standard. Now, with regards to here, I've highlighted the right atrium and the aorta because that's more central. And because we're looking at doing a more minimally invasive approach, I'll remove these. And we're only going to be looking at basically draining from the femoral vein and the jugular vein and returning to the femoral artery, the subclavian artery. If you like, it's a more minimalist approach to doing sort of cardiopulmonary support. And it's really not fair to call it ECMO because what you're really doing is called MyEC, which is minimally invasive extracorporeal circulation. And the circuit that is being described is MyEC type 1, where we drain from the right atrium through a pump bed into an oxygenated aorta. And this is the MyEC descriptions and definitions as per the MyECDIS group out of Europe. Now, with the simple addition of a quick connect cannula, or connector into your venous line, what you can do is that if the situation gets out of hand and the surgery becomes a bit difficult, with me.
Hi, Arthur. We're just getting some comments from the audience to say that you're still a bit choppy.
Okay.
You know,
I might stop the video because that will sort of save some bandwidth. Is that
great.
better?
And no, your voice is still a bit far. It's a bit distant.
Okay. Yes. I don't know what else I can do. I'll bring the microphone. I've got one microphone to bring closer and tell me how that goes. Because I apologise about this. So I'll press on and hopefully this is all right. So we can, by breaking the circuit, we interpose a venous reservoir here. And now we've got a full bypass circuit, which allows the surgeon to tackle anything they like, because they've got full control under full bypass. So you can see how we switch from a simple type 1 to type 4 by interposing a reservoir, which makes it much more flexible to do whatever you need to do. So in terms of components of what makes up one of these circuits, it's broken down into four items: an oxygenator, a pump, a circuit, and a cannula. So for the oxygenator that we have available currently is the Fusion. It offers 2.5 square meters, has a static priming volume of 260 mils, and can pump up to, you can carry up to 7 liters of blood. This is currently meant for bypass only and not any long-term use, but Medtronic's always looking at and investing in the future. And just to highlight where we're going, this is some pictures of a newer oxygenator, which is not yet on the market, but you can see that it's an ECMO device, and you can see the big difference to what is currently available. And this is its cylindrical arrangement of the oxygenating fibers, so there's no areas of stasis. And this will be on the market within the next year, and we're very excited about it. To propel the blood around the patient, we need a pump. And the pump we have here is the Medtronic AP40. It's a 40 mil.
Arthur, sorry to stop you again. It's very, very choppy. Any chance you could come closer to the speaker and speak, because it sounds like we're quite far away. So
is that any better?
This is better, yes.
I'll do my best. I was hoping to be able to call him, but he didn't give me that option. So that's all right.
That's better now. Yep, that's much better. Yep.
We'll keep trying. Okay, so the pump is the AP40. It's a centrifugal pump. It pumps up to 10 litres a minute at a maximum of 4,000 revs, and it can sit on a number of different consoles. It can sit on the Medtronic console, the Performer, the Quantum Heart Lung machine. And it can also sit on our competitors' products by the use of this adapter, which makes it very easy to use. one of the things that's completely overlooked generally are the tubing itself. And this is an example of some tubing that we used to use at our old institution where I used to work. And you can see that after a few days there, there's quite a bit of fibre deposition on it. And this is uncoated tubing. To prevent this happening, we now use coated tubing. And Medtronic offers two coatings to the surface of the extracorporeal circuit. One is Balance, which is a protein coating, and the other is Corteva, which is an active heparin coating. And these help to reduce the inflammatory response by reducing contact activation, platelet activation, and consumption of clotting factors. And all of these together reduce inflammatory response and allow you to sort of run these patients much more easily. And this coating can be applied to the oxygenator, to the tubing, and to the cannula. So the cannula, which is the next most important part of the circuit, because it's the interface between the patient and the circuit. Successful cannulation and positioning of the cannula are key to the success of the procedure. If you want to think about it, it takes the least amount of time to do is the cannulation. But if you don't get your cannulation right, you're going to be running through problems throughout your run of ECMO or your cardiac surgery. So it has to be done simply and properly and to get the best possible result. And in this picture, you can see we've got a patient here, and in their groin, they've had one cannula inserted percutaneously, which is nice and plain, and the other one is by surgical cut down, which is a little bit messy, but still they're both successfully done and both sitting properly in the vessels. So the cannula that we have to support this kind of surgery, we have our legacy VA Medicus family, and these are flexible wire-wound cannula which are thin wall, which have a large internal diameter, which means you get a large amount of flow through them. They come as both arterial and venous cannula, and the venous cannula that we have of the legacy group are best if you're going to use veno-venous through the femoral vein, because they're the only ones that currently that only have vent holes at the tip, which means that you don't get any recirculation if you sit them next to each other. We also have our multi-stage cannula, which has multiple perforations along the length of the body, which makes it great drainage for VA support. Further, in the family of cannula we have the Biomedicus Next Gen. Again, they're flexible, wire-wound, and thin wall with a large internal diameter. And we have them coming as arterial, venous, and what is new now is we have this hybrid cannula, which is both an arterial and jugular venous cannula. It's the only cannula that has dual indication. So historically where I worked, we used to grab an arterial cannula and shove it in the jugular vein to get venous drainage. We have now reclassified this sort of arterial cannula to also be able to be cannulated or inserted into the jugular vein to get drainage. So you can see we've got a red, blue, and this hybrid white cap. Further, we have a double lumen cannulae where we sort of set the cannula into the jugular vein, and we position it so the outlet holes, also the inlets to the cannula, are positioned in the SVC above the RA, and in the IVC below the RA. The outlet of the cannula is positioned exactly opposite the right atrium and the tricuspid valve. So when the blood exits, it flows through the tricuspid valve straight into the right ventricle, and thereby decreasing any chance of recirculation. It needs image intensifiers to be positioned, but it's very handy for doing veno-venous ECMO. In summary, it's a short talk, and I hope you can hear me now. VA or VV extracorporeal support, it is simply deployed, and it is a valuable adjunct to lung surgery as it provides a surgical team a margin of safety and a safety net for some of their more difficult cases. And with that, I thank you, and I hope you heard some of that.
Great. Thanks, Arthur. We had some issues with the volume, but I think we've got the gist of it. So there's some questions up here right now. I guess, Graeme, you have the first question. Basically, it says that how long should we treat patients with ECMO for all ultimate outcome? And I guess this can go for both COVID and non-COVID patients.
Sure. So,
is there a cutoff time?
Yeah, that's a great question. Historically, if you go back 25 years, people, many centers would commonly see, look at 14 days. If the lungs weren't better on VV ECMO after 14 days, they'd say, okay, we tried, it didn't work, and they would stop and the patient would die. So these kind of things became self-fulfilling prophecies. So in time, people realized, largely through the work done at Karolinska Institute in Stockholm, that this practice was misguided. And in fact, there's no magic number for VV ECMO. VA is different, but for VV ECMO, there's no magic number that you should say, oh, the lungs aren't going to recover. And people have continued to push boundaries. So 30, 40, 50, 60 days on ECMO, not for COVID and not under pandemic conditions, but just for ARDS in general, is now becoming pretty standard. So the longest ECMO run ever was published 2 years ago, where a little girl at Johns Hopkins was supported on various forms of ECMO for 604 days. She's now home. So the principle that I think should be adhered to for VV ECMO is once you've committed to VV ECMO, the patient either dies of complications or they survive. You don't say at 20 days or 30 days or 40 days, we've all had enough of this. The lungs don't look like they're going to recover. Let's stop. Because the lungs, if you see these patients, you look at CT scans, you see these lungs which are completely trashed, full of scar tissue and bullae. But if you persist and repeat the CT 12 months after they get out of hospital, the lungs are near normal. So there is no easy answer to the question, but the principle I think is important is don't give up on these patients. If you're going to withdraw care, it has to be for a very, very strong reason. Yes, the patient's had a large intracranial hemorrhage and is not going to be the same person that they were. That's a reasonable indication to stop. But just looking at the calendar and saying, oh, we've been doing this for long enough, that doesn't work. Now, as far as COVID is concerned, we don't know yet. I'm unaware of the longest COVID ECMO run ever. I'm not even sure it's been published yet. Our longest in the experience in Singapore was 30 days, which isn't particularly long for a VV ECMO run, but it was very, very eventful. There was a lot of complications, a lot of problems, but that lady is now home. So I think the same principles should apply to COVID as they do to non-COVID patients, providing the healthcare system isn't being overwhelmed. If you're struggling, if there's just too many patients coming in, then it then becomes a question of distributive justice and resource allocation. And obviously, you know, spending a huge amount of money and resources on a 60-day ECMO run when there are patients dying in the next bed because you don't have a ventilator, that's obviously unreasonable.
Great, thank you. So the next question is from Dr. Edgardo from the Philippines. He asked, what's the experience of Singapore on ECMO and proning for severe ARDS? So what's your experience with proning the patients first and then going on ECMO?
So we didn't need to use ECMO very much for COVID. And the reason for that is because the Singapore government, I think, did a good job of controlling it in the community. So, you know, we received a lot of ECMO referrals. A lot of them were kind of, we're just letting you know in advance. Obviously, transferring a patient with COVID from one hospital to another is not so simple as it used to be. So we appreciated those early referrals. But a lot of the time, the patients had not been proned. And all we did was really insist that the patient have a trial of proning. And in the vast majority, that was what fixed them. And we would continue to follow the patients up remotely, and most of them seem to do well. So again, with or without COVID, I think proning is a key, very strong, simple, evidence-based intervention that should be used in all patients with ARDS, unless there's a clear contraindication. So if they're a multi-trauma patient with an unstable spine fracture, obviously you can't prone them. If they're in third trimester of pregnancy, you can't prone them. But most patients can and should be proned if they have severe ARDS before you think about ECMO.
Great. And you know, you were talking about the ratio. So how often do you need to check their oxygenation, and how long would you keep them on prone before deciding, okay, switch over to ECMO?
So the trials that looked at proning to begin with were proning for about 16 hours a day. There have been a couple of major societal guidelines which have recommended a minimum of 12 hours a day. And occasionally, in some patients, just out of practical need, you just keep them proned almost all the time. And what we usually see is an improvement in gas exchange once they've been proned. And we often get the ECMO referral when they flip them back the next morning, and then the oxygenation goes down a lot. And again, that may be an indication to just flip them back again. It's much easier to just flip them prone again rather than putting them on ECMO.
Okay. I have a question from Dr. Marcela from Indonesia. And she asks, what's the best mechanical ventilation setting for ECMO patients?
Okay.
In your experience?
So I think the principle, ECMO does two things. One is it keeps the patient alive. And second, it facilitates rest of the damaged organ. And it's very important to get both of them right. If you're on ECMO, you're kind of lousy ECMO with small cannulas, and you're only getting, 20% of the patient's cardiac output, and as a consequence, you have to ventilate the patient hard, then you're not doing good ECMO. You're not resting the lung. So in my view, you have to split it in two ways. If we just confine ourselves to VV ECMO for a second, those vent settings that we would use to concern ourselves with oxygenation, in other words, PEEP and the fractional inspired oxygen concentration, they should be titrated to, they should be minimized. We know that there is such a thing as oxygen toxicity, there's denitrogenation, atelectasis. We want to try and minimize the FiO2. PEEP is very useful, but again, we don't need very, very high PEEP, because if we have parts, ARDS is a heterogeneous lung disease. If we apply too much PEEP, yes, we may recruit parts of the lung that otherwise couldn't be recruited, but we also may damage the relatively healthy parts of the lung through overdistension. So a few years ago, people were going for very high PEEP, 18 or 20 PEEP on ECMO. I think most people have backed away from that and usually go for more in the vicinity of kind of 12 to 14 centimeters of water of PEEP. Obviously, very obese patients with stiff chest walls will need higher PEEP to overcome that resistance, but most of the time we're looking somewhere about 10 to 15. The second component of ventilation on ECMO is carbon dioxide clearance. Now, obviously, in patients who are not on ECMO, the two main things which determine that are the delta P, the change in pressure between full inspiration and expiration, and the ventilator rate. Now, doesn't matter what form of ECMO you're running, you always have total control of carbon dioxide levels. So the oxygenator can do it all. So as a consequence, it makes no difference whatsoever. It makes no sense to ventilate the patients with high rates or high pressures. So what I do personally, I always have the peak pressure that I'm exposing the lung to is always less than 20. So the PEEP will be whatever the PEEP is. It could be 8, could be 10, could be 12, but the pressure control or pressure support will never bring the total pressure in the circuit above 20. We know that plateau pressure above 30 is injurious. There is some evidence that there's a linear relationship between the pressure you apply to the lung and mortality in ARDS. So the less, the better. And the same thing applies to rate. There is no need to ventilate the patient on ECMO 20 breaths a minute. In fact, in some circumstances, like pulmonary hemorrhage, you don't ventilate them at all. So we just usually set the vent to a rate of somewhere between 5 and 10, just to make the chest wall move a few times a minute, so that to try and avoid atelectasis. But those are the kind of guiding principles. It's all about lung rest, minimal settings.
So maybe I could put this question to Arthur, who's a product specialist also for Medtronic, and also Graeme. There've been many talk about cannula size and that you can actually achieve full flows with smaller cannulas. What are your thoughts on that? We've had a surgeon who does a lot of ECMO from in Canada. I think many years ago he came to Singapore and he mentioned that you can stick in a 19 and a 21 gauge into even a very obese patient and you'll get good flows. It all depends on the position of the cannula and ensure that the patient's well filled. So what are your thoughts on that?
Hopefully you can hear me. Being a perfusionist, I'll always argue I want the biggest possible cannula in a patient for drainage. It depends on how much flow you want to get out and what you want to achieve, and with the point being that if you don't have adequate filling and you're struggling to get support, you're going to end up causing a bit of hemolysis by having too high suction on these cannulae. So it's a vexed question, which we come up against all the time. But as I was trying to highlight in the talk, optimal positioning will make it work, as will appropriate levels of filling. Graeme's probably seen a lot more than I have of recently of ECMO and positioning of cannulae. So I'd be interested to see what he has to say.
Yeah, so you know, the guiding principle here is you want a short, fat cannula, not so fat that it's right hard up against the wall of the vein, because then with any major shift in intravascular volume, the vein will collapse down around the cannula and obstruct flow. But there is a trend in the last few years to people, particularly on VA, putting in thinner cannulas or smaller cannulas with thinner walls, with the argument that it's better to have some flow. It's easier to get in smaller cannulas, obviously. So the faster that you can establish some flow, the better. And thereafter, if you need to make additional modifications, so be it. I would caution against trying to fill patients excessively just to deal with inadequacies in the cannulation strategy. I think there is strong evidence that patients who are fluid overloaded on ECMO, or in fact in intensive care in general, whether they're on ECMO or not, do much worse if you never get them down to their dry weight. So one of our principal goals in the early days following cannulation is to get that additional fluid off, get them down to their dry weight. And it can be very hard to do if the cannulas are in suboptimal positions or kinked or just too small. So hopefully you have expert surgeons on your team who listen to you and who are willing to go in and make those changes, adjust the position, or insert a third cannula in certain circumstances.
Thanks. So we got a question from Dr. Carlos. Maybe I can answer this. Are there any special technical tips to watch out when inserting for a VV in an obese patient? So generally for VV patients, we tend to go with a percutaneous cannula. But in very obese patients, I agree, it may be difficult because they're obese, they're sick, maybe they're underfilled at the moment, their vessels can be shrunken and collapse. So in very obese patients, generally what we would do here is we would actually do a cut down and splay out the vein very nicely so we can actually see it and cannulate it directly. But the first thing we always do is we put an ultrasound probe and we can see if we get it in. And if we can get a wire all the way in, generally it's pretty safe to cannulate that way. As for the size of cannula in obese patients, because of the angle of going in, it'll be a bit tricky. And what we do is we try to go in a little bit more distal so we actually get a straight cannula in instead of it kinking. And that's what happens when you cannulate through percutaneously that way. So generally we will put an ultrasound probe, we'll put a guide wire in. We'll make sure the guide wire can go all the way to the top. One test is when you slide in the guide wire and you know you're somewhere within the vicinity of the RA, because when your guide wire goes in, you see a little bit of arrhythmias in the heart, and you know there's some irritation in the RA, so you know you're in that right position if you don't have anything else to check with it. Okay, let's look at the next question. Dr. Ronald Karthika asked about maintenance ECMO in COVID and non-COVID patients. Is it the same? You know, is it the same concept, or is it the same way you deal with them? Like how do you maintain the ECMO circuit? You know, is there special things you do for a non-COVID and a COVID patient?
I think the answer to that is no. I think the key differences that COVID patients have that non-COVID patients don't. Obviously, the contagiousness of the virus dominates our existence and makes life slower. It makes it harder to start talking about emergent conversion. If a patient on VV ECMO becomes hemodynamically unstable or has a cardiac arrest, I think it's important that you have already decided as an institution whether or not you're going to convert that patient to VA emergently. That's one thing. Another thing is the duration. We know that COVID patients will generally spend longer on ECMO, which can lead to an increase on the burden on the system. And then lastly, of course, the thrombotic and bleeding complications. And we've seen that many times. The rest of it, I think, is all the same.
So, Graeme, we're coming up to the time. We've got 5 minutes, and maybe Arthur, you can help us. You told us about some new cannulas out there that are lined and prevent fibrin formation. Now, especially when it comes to VV ECMO, we've had a few patients that we run when they have bleeding issues. We just stop the heparin completely, and we run the VV without any heparin or any anticoagulation. What are your thoughts on this? And especially when dealing with COVID patients, you know they are very prothrombotic. So would you apply that same concept if you have a bleeding issue in a COVID patient?
So you put me in a difficult position, Harish. If I put on my Medtronic hat, I'd have to say, look, if you're going to use cannulae and an extracorporeal circuit, you're going to have to anticoagulate. As a perfusionist, I would tell you, anticoagulate, please. But as someone who's been a practitioner, and done ECMO, I know you get to situations where you go, if you've got enough flow, you get enough washing, and so you can maintain, if you like, patency in the cannula and in the circuit, but it requires adequate flows to go through. And with some of the cannulae and the services that are available, like with the heparin-coated cannulae, they will actually help you maintain patency and keep the cannulae open. But putting my Medtronic hat on, I'd always ask you to give appropriate doses of anticoagulation to keep your circuit patent.
Graeme, your thoughts?
Yeah, I think the larger the patient and the more circuit flow you have, the more you can get away with turning the heparin off. So the longest we've ever had to turn off the heparin in a non-COVID patient was 23 days because he had a hemorrhagic cerebritis. But he did very well and came back into the ICU 3 months later to thank us all and had no problems at all. On the other hand, if you spend your time looking after neonates on ECMO, you try turning the anticoagulation off on them, you'll probably end up changing the circuit twice a day, and the outcomes will not be good. So I think it depends a lot. In general, I agree with Arthur. I think, you know, there is a reason that blood clots when it goes through an ECMO circuit, and you need to try and stop it. What the problem with COVID has been is that they simultaneously bleed and clot at the same time. And we've had a lot of problems with patients bleeding. Then we have to turn the heparin off. And then not so much the ECMO circuit, but the CRT circuit clots off. And we've had to be changing it every 8 to 12 hours. It's been a real nuisance. And again, these things are not trivial. One, there's the cost and the resource consumption, because you've got nurses not at the bedside, they're busy priming CRT circuits half the day. But there is blood loss through a spoiled CRT circuit. So it's been a real difficulty, and various ECMO centers have tried different things. They've tried driving up the APTT to around the 90 mark. Some of them have tried bivalirudin or argatroban. But again, at least in Southeast Asia, argatroban and bivalirudin are not cheap, and they're hard to come by. If you're proposing to, you know, run it by an infusion for 2-3 weeks, you'll struggle to get the supply. Or at least we would in Singapore. So the answer is not clear to me yet. We'll have to wait and see more data.
Well, great. Thank you very much, Dr. Graeme and Mr. Arthur. And well, it's 9 o'clock. I think we had a great discussion, great presentation from both of you all. And we've answered quite a bit of questions. Well, with that, I would like to conclude today's session. And thank you again, everybody, for attending.
Thank you.
All right, cheers.
Thank you. Apologies for the sound.
No worries, no worries. Cheers, bye.